Now we have Dr. Nada Jabado, who's going to speak about brain tumor lab research and biobanking.
Bonsoir à tous. I was hoping that Kolya would be here for gender equity, but then you'll have to see me without my hair and just pretend I'm kind of like a bi-gender or whatever. Je vais parler aussi en français parce qu'on m'a demandé de parler en français. C'est une langue que j'adore. And Iassos, Tikanis, for those that are here, that I know that are Greek. And I could say a few words in English and Spanish as you want, but we're not here to kind of be facetious, but maybe to see why research is so important for the pediatric cancer that we care about in here. I see friends, I see colleagues, I see patients that lost parents that lost children, parents that have children that survived. So it's a mix that makes me a little bit emotional. Quand j'ai commencé mes études en médecine, c'est pour traiter et pour bien traiter les patients. And what I face treating patients with cancer is sometimes you cannot win. And in those cases, this is where you need to search to understand why you're not doing it, why it's not happening, and for those that will come later to provide them with an answer. Et pour ceux qu'on est capable de traiter aujourd'hui, est-ce qu'on peut mieux les traiter? Est-ce qu'on peut diminuer ces effets secondaires? Est-ce qu'on peut faire en sorte que leur survie ne soit pas une survie, mais une vie de qualité? Research is fundamental, not only in understanding and being better able to treat cancer, whatever cancer, pediatric or adult, but also to provide alternate solutions to a cure. We want to cure, but we want to cure with a quality of life. We want people to be as normal as they were before their cancer. And this is a potential that's real. And by doing more research, by understanding better how the tumor is animated, what drives it, by providing earlier care, more targeted care, we can provide this type of hope, and we're doing it already for some of the cancers. Il y a une tumeur qui s'appelle un gangliogliome avec une mutation qu'on ne connaissait pas avant 2010, qu'on a découvert en 2010-2011. Maintenant, on sait pour ces patients qu'on fait une petite biopsie et bientôt on fera juste une ponction lombaire pour prendre du liquide céphalorachidien. On trouvera la mutation là-dedans et la réponse est une thérapie orale. Pas de chirurgie, pas de radiothérapie, pas de chimiothérapie. Restent bien sûr les effets secondaires de cette chimiothérapie qui est quand même de cette pilule qu'on va prendre au long cours. But so many adverse effects that are completely spared just because we're able to understand that this is the main mutation, the main genetic alteration, and you've heard about genetics, that animate this tumor. And this could be the rule because we're finding more things that are driving brain tumors, sarcomas, leukemias, that if treated specifically, can decrease significantly the burden of disease. So what is it that I do? First of all, I'm not the only one. I have a lab, and this is really the people that deserve the whole credit, the people that work and work their heart off, their hands off. Tenzin is one of them that's here. Livia used to be a postdoc in Michael's lab, and we collaborated a lot. Those people are the ones that are making all of the work and are making our ideas come into practice. So what is it that I started working on pediatric brain tumor and a very hard, intractable brain tumor by the name of high-grade glioma. DIPG, diffuse intrinsic pontine glioma, is part of this. Just to give you an idea, children and young adults with this disease have a life hope of barely 5% at 5 years, and I'm being very generous with the 5%. It's actually a death sentence. Some of the parents would remember that the first thing we tell them when we give them the diagnosis, there is no cure. We could give radiation therapy just to palliate, meaning to give a little bit more of life, just 6 to 9 months. And after that, it's downward hill if it's not already starting. What an awful thing to say. It's unfortunately up today. This is something that we're saying. So my group was the first to identify what is it that animates, what's the mutation, what is it that's driving this tumor. Great. That means that we could find treatment. Unfortunately, in this case scenario, we uncovered a very new mechanism of oncogenesis. This mutation that we found, we're doing something completely specific that no one would have imagined would be doing. It's almost like learning a new alphabet. And now we have the letters, we're forming the words, and hopefully we'll form the sentences. We have the full vocabulary, but we had to do it from scratch. And those mutations, I'm not going to go about them. They're not only in brain tumors. We found them in another type of brain tumor, which is called ependymoma. We found them in other bone cancers that are sarcoma, undifferentiated sarcomas, and also in osteosarcoma, believe it or not. We found them in head and neck cancers. We found them in subgroup of leukemias. So from one mutation, from one entity, just by really doing diligent work and looking at genomic data and looking at samples in an unbiased way, we're able to identify that what we uncovered for those tumors is also real for other subgroups. And that's important. Why is it important? Because those other tumors are intractable, meaning they will not respond to regular therapies. The other thing, the more you have entities that have a given alteration, pharma becomes interested. And then you can hope to lure them to bring and work with you to provide a cure, because this is what we want. So from one cancer, specific mutation, a very new mechanism of oncogenesis that we uncovered. I call it Peter Pan. Those tumors are actually a stem cell, meaning something that creates your brain, for example, but that stopped, that stalled, and want only to create a brain. It doesn't want to differentiate, to become a neuron, and other things. It really is stalled in development. It's Peter Pan. It doesn't want to age. And what we want to do is now unlock it and allow it to age and really become less harmful. I'm using the word unlock. I'm not using the word treat with high-dose chemo, with everything, because everything was tried. There is nothing that works. And maybe a simple drug, something that really would unlock this mutation, will allow us to gain huge cures. And this is a possibility. And there are 2 adaptive trials that are starting based on our result in the next year. And this is the fruit of the collaboration and all of the money that was invested in our research and in our collaborators' research. Profile and signature, you've heard about triceps. So when I started using genomic data, it was in 2010. We were actually, my group was the first one to publish, and I'm not taking credit for that, just to tell you that really it's not that we're in Montreal and the children that we're not at the forefront of technologies. We're here, and we have them, and we have an international collaborative network. So when we saw what this genetic information could give us on a patient's tumor, on the genetic makeup, we said, okay, we should try and apply it systematically to every single cancer case that we have, not only the brain tumor that I care about, but leukemia, sarcomas, whatever, any unsolved mystery. Following consent, and this is why we have Emma, and we have Stephanie, and we have protocols, and we have RIBs. So those parents and those children are consented for research. And from there, we get the tumor, we get the material that's abnormal, we analyze it with whatever mean is needed to analyze it. It's sequencing using next-generation sequencing. I could bore you with word, but we go in depth and see what is the genetic makeup. We extract a signature. You've heard of that. Can we find it in the blood? Because if we want to trace this tumor as it's responding or not responding, it's better to have a plasma marker, a blood marker that you could easily track instead of going and biopsying, especially the brain and other areas. Surgery, especially in children, is not needed. And this is possible for solid tumors, for sarcoma. Sometimes, oftentimes, the blood gives you a beautiful answer of what responded and what's left, and you could use it without using serial sampling. And this is part of what we're integrating, and this is something that's actually funded by the Sarah Cook Funds, and by Cedars, and by Terry Fox Profile. The other thing that we do is we enrich, we get, and we do assays. So for example, when there is a surgery that's ongoing in the OR for a brain tumor, I get CSF, and oftentimes, even before the pathologist could give an answer, I know if the mutation that you don't want to see, or the one that we want to see because it's targeted out there, within 24 hours. And my hope that this be now something that's systematically done, not in a research, but in a clinical, because this is 24 hours of wait, only 24 hours of wait for those families and for those children before we start embarking on trials or knowing what we have to account for. The other thing is that we do is we go, and every single tumor is part of a bigger bank. bank that's constituted here, bank that's constituted at Saint Justine, across Canada, across Europe, across the US. All of this material is stored and analyzed together. Why is that important? Because by having all of these data sets, we can find trends. You've heard about AIA, artificial intelligence. Well, this is part of it. Can we find trends, signature, molecular signature? You saw what the molecular signature could do in a sarcoma case. It could orient you for a given treatment or say that this patient will not respond to this treatment. So this is what we're trying to gather, that at the time where we take a tumor, we know what's the genetic makeup, what is it, the molecular profile of it, what is the signature for response to this or that treatment, and orient to the best diagnosis and the best therapy to be put up front. My hope is that those targeted therapy that you're hearing about really replace radiation therapy and toxic chemotherapy, for which the side effect we're starting to see because now those patients are living longer and longer. So the other thing that we do is we're trying to see what is the cell of origin. So this is funded by a Genome Canada grant that I have, but also by a generous foundation from We Love You Connie, from Terry Fox, from the Cooks. It's a lot of money invested in this program that's benefiting not only sarcoma research, leukemia research, brain tumor research. It's going to benefit a lot of patients with cancer, because what we're getting a blueprint of normal development within the brain and within those other organs where the brain tumors, the sarcomas, and leukemia develop. And we're knowing where those tumors start. What is it that they are doing? Are they kind of really subverting one given pathway, multiple pathway? That will help us actually time them, maybe dream of preventing them from happening or screening for them earlier on. So again, all of this is research and needed research, but it's research applied to care. Because whatever we have, we take, we rectify sometimes diagnosis, we add to the diagnosis. We're not replacing diagnosis, we're just making sure, based on our mean, that it's the most accurate possible. And we're providing potentially alternate pathways of care when they are needed. And sometimes we're saying this is where, as far as we can go today, but hopefully tomorrow with more information, especially from studies like this, we can provide an answer similar to what we were able to gather in the last 5 to 7 years. This is not my work on, it's really part of a very big and international collaborative. I created iChange, which is the International Childhood Astrocytoma Consortium that regroups about 20 countries and multiple different investigators. The Genome Canada grant that we have is between iChange and MAGIC, which was the Medulloblastoma Consortium created by Michael Taylor. It's a merger of really multiple different people with the same aim, better understand and especially better treat, and really decrease the burden of disease to those children and for their family, and even for young adults and adults, because it's extending, as I said, beyond the pediatric and young adult cancer that we're treating. And I would like to thank you.